So next we will deal about transgender endocrinology. I think this is very important. Once you enter into the residency, a good or at least the basic knowledge regarding the approaches to a patient who is transgender is very important. What are the concerns that you need to address and how to manage and follow up a transgender person is very important. And few points from this area can also be a potential question for your upcoming exams also. Now, before going into the topic proper, let's analyze some of the basic terminologies. What is chromosomal sex, gonadal sex, anatomic sex, and brain sex? So, chromosomal sex means whether the patient is XX or XY. You know that if the chromosome or the karyotype is showing XX pattern, then the patient is destined to be developed as a female, and XY is going to develop as a male. So that is the sex determined by the chromosome. Then as per the chromosome sex, their gonads will develop. The XX will develop ovaries and XY will develop testes. So that is what we call as the gonadal sex. So the patient who is having an ovary or a person who is having a testis is said to be a gonadal male, whereas an individual who is harboring an ovary is said to be a gonadal female. Now we have anatomical or phenotypic sex. Phenotypic sex means those with the XX karyotype with an ovary as the gonad, you expect female or non-virilized external genitalia, non-virilized. Whereas those with 46XY with testis as the gonad, you expect a male type or virilized genitalia. So far everything is in accordance. And finally, so these three are the classically described sex variants: the chromosomal sex, gonadal sex, and anatomical sex. So in addition to that, there is one more thing, which is the brain sex, which is our brain's perception of that gender. So even if everything is in accordance, the karyotype, the gonad, the external genitalia, still our perception of our own gender can differ. It can be discongruent to the four set sexes. It can be discongruent with our gonadal and anatomical sex. So it is nothing but the perception of our own brain regarding our gender. Okay, so it can be influenced by so many factors. So what are the factors that determines the gender identity or the brain sex? It could be genetic factors, prenatal exposure to androgens. For example, in a 46XX female, genetic female who is having CAH. In CAH, who is uncontrolled during or untreated during pregnancy, in utero life. What happens during in utero life? There would be so much exposure to androgens. So such androgen priming to the brain can result in a male type behavior in those patients. So those patients, CAH patients who had a lot of androgenic exposure during in utero period and in the postnatal period, even if they are female by chromosomal sex and gonadal sex, they would tend to have a different gender identity. Even though their assigned sex is a female, they could be having a gender identity of a male. Why? Because they has had good prenatal exposure to androgens in the prenatal as well as postnatal. So both prenatal and postnatal exposure to androgens can determine or can play a role in determining the gender identity. Then the functional androgen receptor is having a receptor is very important, and also environmental factors, the socio-cultural factors and the surroundings that we are living in, that has also got a large bearing or influence on determining one's gender identity. Now, very important, in fact, the most important area in the transgender endocrinology is to have a sound and thorough knowledge on these terminologies. So we will discuss that one by one. First, we will discuss from below upwards. What is gender identity? So gender identity is what I've been calling it as brain sex. That means the patient could be having one chromosomal sex, gonadal sex, and phenotypic sex. But what matters to that person the most is how he or she, how the person perceives oneself, or what gender does the person perceives themselves to be in. So whatever be the external genitalia sex, whatever be the appearance, the person may perceive oneself to be a male or female. That is what is called as gender identity. So irrespective of the other type of sexes, what the person perceives oneself, or it is otherwise called as internal deeply held sense of gender. What the person thinks of oneself, that is gender identity, or how the person identifies himself or herself, that is gender identity. Now, gender dysphoria, what do you mean by gender dysphoria? So how the person identifies oneself. Suppose a person identify oneself as a male. The person thinks that he is a male, but the assigned sex, the sex of rearing of him by the parents and the sex assigned by the society, could that be of a female? So if when the assigned sex and the sex perceived by oneself is different, that causes significant mental trauma and uneasiness and distress to the patient. So this distress, uneasiness and mental trauma to the patient is what we call as gender dysphoria. When there is an incongruence between the perceived sex and the assigned sex. When they are different or when they doesn't match, we call it as gender dysphoria. Third, what do you mean by gender expression? So gender identity means what the person think of himself or herself, what the gender he thinks himself or herself is having. And gender expression means how they express their gender identity. Suppose a person thinks that he is a male, he would dress like a male, he would have haircut like a male, he would talk like a male, and he would behave like a male. So whatever things that he is expressing to the outside society in the form of his dressings, in the form of his language, in the form of his haircut, so all these is collectively known as gender expression. What are the external manifestations is what we call as gender expression. How the person expresses oneself to the outside world. That is gender expression. Now, what do you mean by gender role? Gender role means what role does the patient play in the society? Does he play the role of a male? Does he play the role of a female? That is what we call as gender role. Now, sexual orientation, as you all know, is the patient's physical and emotional attraction. Whether the person is attracted to a male, whether the patient is attracted to a female, to the same sex or the opposite sex, that is what we call as sexual orientation. Now, finally, what do you mean by the term transgender? So, the transgender means it is a state where that person's perceived gender and assigned gender is different. That is when we call them as transgender. There is a difference between the sex assigned, sex of rearing of the individual and the person's perceived gender, or the gender identity does not match the assigned gender. That is when we call the individual to be transgender. I hope these terminologies are very important, and moving forward, a sound knowledge and a clear understanding of these terminologies is of very much importance. Now, what are the things that you have to look up in a patient who is a transgender? You will have to address the hormonal effects, whether gender affirmation surgery is required, the fertility aspects, the bone metabolism, and also the cancer risk. Now, a person who has been having a sex of rearing as a female, but he perceives himself as a male. That person perceives oneself as a male. So, what is the role of hormonal therapy there? Okay, already assigned as a female, but now wants to be a male. So, for the person who wants to be a male, he wants male secondary sexual characters, and the person doesn't want female secondary sexual characters. So, there are two components to the hormonal therapy there. You want to block the unwanted secondary sexual characters, and you want to promote the required secondary sexual characters. So, the endogenous sex hormone levels has to be reduced. So, in our case, the female sex hormones needs to be reduced, and replace the sex hormone levels consistent with the individual's preferred gender identity, which is called cross-sex hormones. So, now how are you going to reduce the endogenous sex hormone levels? You can give a GnRH analog, or you can give a estrogen blocker to reduce the effect of estrogen, and subsequently you can give an androgenic drug like testosterone to promote male secondary sexual characters. So the treatment team for a transgender should include a medical provider, preferably an endocrinologist who has sound knowledge in transgender hormone therapy. There should be a mental health practitioner who is knowledgeable in gender dysphoria or gender incongruence and about the mental health outcomes of transition from one sex to other. And there should be a primary care provider able to provide care appropriate for transgender individuals. So this is nothing but a multidisciplinary management aspect. Now, do you give hormone therapy in all patients who wants to switch their sex? Individual who is being reared as a male so far now wants to convert to female. So is approaching you. Will you give hormonal therapy? There are specific set of criteria. One, there should be well documented gender dysphoria. That is where the role of a mental health provider or a good psychiatrist comes in. He should talk with the patient. You should assess the distress that the patient is experiencing, and there are gender dysphoria scoring scales with which you can assess the severity of the gender dysphoria the patient is suffering from. So first you should establish the severity of gender dysphoria, and you should make sure that the patient has that capacity to make a fully informed decision and to consent for treatment. That means he is in his sound mind and his judgment is not clouded by any situations. And the patient should be having the age of majority in a given country. The age of majority in a given country. If any medical or mental health concerns are present, they must be reasonably well controlled. So these criteria should be satisfied before initiating hormone therapy. Now, what are the physical effects of hormone therapy? In a person who has been reared as a female, now wants to convert to a male. That is female to male. This is male to female. So female to male now means the person requires more of male type secondary sexual characters like deepening of voice, clitoral enlargement which could resemble a penis, growth in facial and body hair, stoppage or cessation of menses, breast atrophy, and they would require reduced fat mass percentage. Also, those who wants to convert to a female, they require good breast growth, reduced erectile function, reduced testicular size and increased body fat mass. So their requirements are opposite when they want to switch from one gender to other. So how to induce this puberty and all, it is not required for you for the exam purpose. It is just how you induce puberty in a patient with hypogonadism. The dose and all is almost similar in male and female pubertal induction. So I'm not going into much of the details. And two important points which can be potentially be asked in the exam is, once you start testosterone therapy in a person who now wants to become a male, the target testosterone level should be kept between 400 and 700 nanogram per deciliter. Okay, this value is given in milligrams and you should keep it in mind. This is the target, 400 to 700 nanogram per dl. And in individual who wants to convert to female, the serum testosterone should be kept less than 50 nanogram per deciliter. Very important. You want to reduce the testosterone concentration. How are you going to do that? Either by giving a GnRH analog or by giving anti-androgens. You can give spironolactone, cyproterone acetate, etc. to reduce the testosterone levels. And the serum estradiol with your supplementation, you should keep it between 100 to 200 picograms per ml. So this is very important. The testosterone level should be less than 50 nanogram per deciliter, and the estradiol range should be between 100 to 200 picogram per ml. And the anti-androgens that you can use include spironolactone. This is to avoid the excessive androgenic, because the person is actually a genetic and a gonadal male. So you expect the testis to produce more androgens. So if the person wants to convert or become a female, you want to suppress the endogenous testosterone production and action. For that, you can give spironolactone, cyproterone acetate, which has got androgen blocking property, and or 5-alpha reductase inhibitors. So this is usually given in addition to GnRH analogs. So GnRH analogs, they include duprolide, goserelin, hysterelin, etc. So usually given in those who cannot tolerate anti-androgens and those who require a lower dose of estrogen. So these are the indication of GnRH analogs. When combined with estrogen, GnRH analogs effectively lower the testosterone levels. Now, what about gender confirmation surgery? When do you consider gender confirmation surgery? That the person is already a male, is having male phenotypic characteristics, now want to become a female. So obviously the physical appearance needs to change. So again, just like hormonal therapy, there are set of indications like well-documented gender dysphoria should be there, the legal age of majority. In India, it is 18 years and the patient should be receiving gender affirming hormones for at least 12 months. So for the last 12 months, the patient should be receiving the gender affirming therapy. So suppose the patient, if the person wants to convert into a female, the person should be receiving estrogen for at least 12 months continuously prior to this date, and the person should be living full time in the new gender role for 12 months. That means if the person wants to convert to a female, that individual should be living as a female for the last 12 months. That is also important, and the control of all the risk factors and comorbidities. So these values you should keep in mind. The 18 years is the legal age of majority, and the patient should be living as the desired gender and should be receiving the gender confirmed hormonal therapy for the last 12 months. Now, what are the different surgeries that are being performed? One is the facial surgery, the chest surgery for reduction of breast development, genital surgery for clitoroplasty and all, then reduction thyroid chondroplasty, then voice modification surgery, rhinoplasty, facelift surgery, liposuction, pectoral implants. So many surgeries are available as gender reaffirmation surgeries, not only in the genital area, but also in the face, voice changes, breast changing surgeries. So many surgeries are available. So summarizing, even though I have covered it in a bit of detail, only the important points required for the exam would be the definitions. So they would give the definition and will ask you to identify the correct one among the options. So that definitions should be thorough for you. And next is regarding the certain values which I have emphasized: the target testosterone level, the target estradiol level, the target testosterone level in a person receiving estrogenic therapy and all. So those values also you should keep in mind. So sometimes they would give a case scenario also, and you will have to address them accordingly based on the concepts that you have learned.